And just a quick disclaimer note that please note that the views and opinions expressed during the event are solely those of the speaker. Server does not have any contributions to the content presented, and the information provided is for educational purposes only and should not be considered as medical advice or endorsement of any specific treatments or products. And additionally, the presented materials may contain off-label information for which some of these therapies may not have been approved by Health Canada and not available in Canada yet. And also we are honored to have wonderful speakers tonight. First speaker is Dr. Vogel, a highly respected oncologist and scientist from Toronto General Hospital and PMH. Dr. Vogel is known for his significant contributions to clinical studies to improving treatments for CCA. His research and clinical works are truly advanced the way we approach CCA care, and we are grateful to have him with us tonight. We also have Dr. Rebecca Auer, a surgical oncologist and senior scientist at the Ottawa Hospital. Dr. Auer is also a professor of surgery at the University of Ottawa and a co-founder of the Canadian Cholangio Collaborative. Her dedication to both clinical care and research has helped pave the way for better patient outcomes, and her advocacy for CCA patients has been a driving force for change in the medical community. We also have two incredible individuals who will share their personal stories with us tonight. Mr. Ihab from Mississauga is a devoted husband and father who is battling recurrent CCA. He's using his experience to turn hardship into a strength and inspire others facing similar challenges. And we also have Donna Fox with us tonight. He is a CCA survivor from Waterloo. Donna has turned his own journey of hope and resilience into a platform for others. His initiative, Running with Hope, is an inspiring effort to raise awareness and support for those affected by CCA. So before we dive into tonight's session, let me quickly walk you through the agenda of tonight. First, Dr. Vogel, he kindly provides us with the latest medical updates in CCA, including advancements in treatment and molecular testing. And then Dr. Auer will guide us through discovering valuable support resources and advocacy opportunities for patients and caregivers. Following that, we will hear from two patients, Ihab and Donna, and they share their personal stories and experiences in the CCA journey. And then we will wrap up the session with the Q&A session. It's going to be the questions and involvement of all of you. And we are happy to have such an incredible group of experts and individuals with us tonight, and we look forward to a great discussion. So by this, I will pass it over Dr. Vogel. Dr. Vogel.
Yeah, thank you very much. So I would share my screen. I think it's easier when I...
So do you want me to... I will stop sharing and you can share your screen.
I can share now. So So first of all, thank you very much for inviting us and making this webinar possible. I think it's a great opportunity to connect and discuss some of the latest advancements in the treatment of cholangiocarcinoma. And I just want to give you like a brief introduction. I mean, when we talk about biliary tract cancer, we have to acknowledge that these are actually different subtypes. So we have patients that have intrahepatic cholangiocarcinomas, which are really inside the liver. As you can see here, we have those patients with extrahepatic cholangiocarcinoma when the main bile duct is affected or the tumor starts growing here. And we have patients that have a gallbladder cancer. So it's a little bit the question, where does the tumor arise from? And in general, it has not such a significant, strong impact on how we choose our treatment. But I think in recent years, we have learned that there are a lot of druggable alterations in cholangiocarcinoma, which means genetic alterations, which on the one hand cause tumor growth, but on the other hand are also interesting target to stop the tumors. And we know and we have learned that the frequency of these genetic alterations is different between intrahepatic, extrahepatic, and gallbladder. So depending on where the tumor stems from, there may be different genetic alterations, and this is important when we think and plan for our treatments during the disease. In terms of how frequent are these tumors, the data are okay. It depends a little bit in which setting we are talking. So here I have summarized data from different trials. So some trials are for patients that have received surgery and get additional chemotherapy, basically to increase the chance of cure. And you can see that in these trials, we have a lot of patients with extrahepatic cholangiocarcinoma, which is basically due to the fact that when these tumors grow in the main bile duct, patients tend to develop cholestasis, so that basically the bile cannot flow through the bile duct. And for example, the eyes and the skin of the patients turns yellow. And with that, it's an early sign of this tumor, which offers many of these patients the possibility of surgery. If the tumor arises more inside the liver, the early signs are really difficult to acknowledge, and sometimes these tumors are only detected at a very advanced stage, and then surgery, for example, may not be possible anymore. When we look at patients, when we look at trials that look at the efficacy of first systemic therapy, we can see that the distribution between intra and extrahepatic cholangiocarcinoma is quite evenly distributed. And overall, unfortunately, the numbers of cholangiocarcinomas are really increasing over time. This is one of the latest updates on the incidence of cholangiocarcinoma. And it's interestingly not so much the extrahepatic tumors that are on the rise, but the intrahepatic cholangiocarcinomas. And one question is, and a question I always get from my patients, why did I develop this tumor? And what we have learned and what we know is that many of these patients have now really reason why they developed the tumor, which is unfortunate. But a lot of people also have underlying chronic liver diseases. Yeah, and these chronic liver diseases may not only cause liver cirrhosis, but also lead to liver cancer, which can be hepatocellular carcinoma or cholangiocarcinoma. And reasons for these chronic liver diseases could be viral diseases like hepatitis B and C, but also the new modern diseases like fatty liver disease caused by too much alcohol or by obesity. And this can actually lead to chronic inflammation in the liver, and with that, to tumor development. This is a very busy slide, but this is how we kind of illustrate the way how we treat patients today and which options do we have. And I would like to guide you a little bit through these cartoon. And first of all, we need to decide at which stage is the tumor diagnosed. So do we have an early tumor or a more advanced tumor? When we are talking about early stage, we know that surgery is the best possible treatment, but we also know that the recurrence rate of these tumor type is very high. So we try to add systemic therapy after surgery, so-called adjuvant therapy, in order to increase the chance of cure. When we have a more advanced disease, many of these patients are now candidates for surgery anymore. And here we really need to apply systemic therapies. And there are really some remarkable breakthroughs in recent years. So one is that we have the targeted therapies, which I mentioned before. So we recommend molecular profiling very early on. So we need to understand which genetic alterations can be found in these tumors. Then, as first systemic treatment, we offer today chemotherapy in combination with immunotherapy. And then you can see all these targeted therapies in the lower level, so which means these therapies are usually given once the patients are not responding to the first-line treatment anymore. So if they have received chemo plus immunotherapy and the tumor still or continues to grow, we need to switch treatment, and then it's basically the time for these targeted therapies, and depending on the genetic alterations, we can apply different treatments today. These are some of the data and the way how we depict the efficacy of treatment. So we have these Kaplan-Meier survival curves, and we know that the systemic treatment is really not good for cholangiocarcinoma. It's a very aggressive tumor, and we know that many patients really die from this tumor within the first 1 or 2 years. And when we apply combination therapy, gemcitabine, cisplatin, we can significantly improve overall survival. And we have now a couple of studies that looked at the combination of immunotherapy with chemotherapy, because we know that immunotherapy alone is not effective enough. And again, these are the Kaplan-Meier curves, and what we have seen is that the median survival time with the addition of immunotherapy is significantly improved. And what we always like to highlight when we talk about these immunotherapies is that we do see the benefit of these treatments later during the treatment. So we have more patients that have longer survival. We call it even long-term survival. It's of course always a little bit the perspective on the definition of long, but for this very aggressive tumor type, 2-year survival is considered as long-term survival. And when we increase the rate from 10% of 24%, which means we more than doubled the number of patients that were able to achieve this long-term survival. And a second study also reported a significantly longer survival for those patients that were treated with the addition immunotherapy, which did not add a lot of toxicity, and therefore this combination is now considered as standard of care in the first-line setting. But as you also can see from the survival curves, I mean, eventually the tumors are progressing on treatment, and then we need to switch the treatment. And we have now learned, and this is what I already started with in the beginning of my talk, that there are differences between intrahepatic and extrahepatic cholangiocarcinoma. And all these little dots are basically the genetic alterations that can be found in both tumor types. And you can see that there is a lot of overlap, but the numbers are different. So depending on where the tumor is located, there's a higher or lower likelihood that we detect any of these genetic alterations. And for many of these alterations, we have today targeted therapies available. And this is just a summary. You can see on the left side the frequencies of these alterations, which can be found between 10 to 15%. So these are rare genetic alterations in a rare tumor type. So it's very challenging to do clinical trials. And on the right-hand side, you can see that we have multiple drugs and combinations already today available to treat these patients. Of course, some of them are not improved. So this has been mentioned before. And access to these therapies is really a challenge, specifically in Canada. And this is definitely something we all need to work on, that we have more and better and easier access to these targeted therapies. And this is a summary of the latest approvals in cholangiocarcinoma. So we started with gemcitabine cisplatin. Then for many years, we really had no progress, no new improvement. In the upper side, you can see that now we have the 2 checkpoint inhibitors approved, which is really good, and they are both available in Canada. And then in the lower part, you can see all these targeted therapies based on smaller and larger clinical trials. And one we would like to discuss a little bit more in detail today is actually one of the most frequently occurring genetic alteration, and the so-called IDH1 mutation. And the efficacy of And maybe to start with, what is really also important is we need to detect these alterations. And I mentioned it already in the ESMO guideline that there's a strong recommendation for testing. And there are different ways on how we can identify these alterations. And I also mentioned that there are many different mutations and other genetic alterations that can be found in cholangiocarcinoma. So we usually recommend broad molecular sequencing, so-called NGS. And with this approach, we can detect in the same assay different genetic alterations. So that is basically the most comprehensive analysis. And I strongly recommend for all of our tumors, as we have done in the ESMO guideline, that patient really gets very early on these broad molecular profiling to identify the genetic alterations. For some alterations, we know that the drugs may even be active when we see the target in the so-called immunohistochemistry, and which basically indicates that we have a higher expression of a specific protein. One is, for example, called HER2 on the surface of the tumor cells, and then the drugs, antibodies can bind on this protein and can basically kill the tumor cells. So immunohistochemistry is another way on how we can basically identify these genetic alterations. And the most frequent alterations in intrahepatic cholangiocarcinoma is the so-called IDH1 mutation, and the efficacy of the drug that can be used, ivosidenib, has been tested in a phase 2 and a phase 3 study, so a large study. And the phase 3 study means that half of the patients are or here two-thirds of the patients receive the new drug, ivosidenib, and 1/3 of the patient receives placebo. And with that, basically, we generated the evidence that ivosidenib indeed improves the survival in patients with an IDH1 mutation. There was a crossover permitted, which means when patients received placebo and they had progressive disease, the patients were unblinded, and if they really have received placebo, they were allowed to receive ivosidenib, which is important because the primary endpoint with that is the so-called progression-free survival, basically the time it takes for the tumor to continue to grow. These are the so-called baseline demographics of the patients, which means so we have a slightly or better understanding which patients have been included in the clinical trials. And you can see here, and this is also an interesting observation, there are actually more females in this trial. And this is something we have observed, that these IDH1 mutations tend to occur more frequently in female patients than in male patients. But we don't really know why that is the case, but this is also reflected here. 2/3 of patients are female and 1/3 are males. The median age is 61, which is a little bit younger than what we usually see. So also age seems to be something that is different in patients with IDH1 mutations. And many of these patients have received prior therapies. I mentioned before, these type of alterations are mainly found in intrahepatic cholangiocarcinomas. And we already also talked about the underlying chronic liver disease, and you can see that some of these patients had a viral hepatitis and some had an alcohol abuse, so there are some chronic liver disease. And this was the primary endpoint. So with that, basically, we defined the efficacy of ivosidenib, and what you can see here, this is basically the time it took, or the time the tumor were stabilized in these different patients, and the time was significantly improved with ivosidenib. And when you look at the number of patients that were still without tumor progression, the numbers are clearly higher in patients treated with ivosidenib. So there was hardly any patient that did not progress within 6 months. And you can see here in those patients with ivosidenib, there were still around 1/3 of patients which had not progressed after 1 year of treatment. And this also translated in a longer survival. So you can see here in the gray curve, the patients that have never been treated with ivosidenib. The orange curve is the ones that have received ivosidenib in the first-line setting, and the blue are those patients that crossed over to ivosidenib. So they were initially treated with placebo, and once they had progressive disease, they received ivosidenib. And you can see the survival is almost as long as those that were treated upfront with ivosidenib. So overall, we can conclude that the median overall survival of these patients was almost doubled with ivosidenib compared to those patients that were only treated with placebo. And one important point are, of course, the side effects. So when we talk about efficacy, we also need to talk about toxicity. And you can see many of these patients mainly complained about so-called GI toxicity, so nausea, diarrhea, but also fatigue or abdominal pain, decreased appetite, and again, vomiting, which is also related to the nausea, of course. So these GI toxicity and fatigue are certainly the most frequent side effects we have observed with ivosidenib. But I also would like to highlight that we observed these symptoms also in the placebo arm. So in those patients that did not receive the active treatment, which indicate that some of these symptoms may not be directly linked to the drug, but something that occurred during the treatment in the trial. And at the moment, and this is very good, we have a large phase 3 study which aims to add and generate more safety data for ivosidenib. And specifically in countries in which ivosidenib is not available, such as Canada, I think it's a great opportunity to get access to this treatment. So we are really trying to include all our patients in this so-called PROVIDE study, in which all patients, so there's no control arm, all patients will get ivosidenib. And we have here, as you can see, presented the first data at a large congress, the ESMO Congress, one of the largest cancer congresses in the world, last year in Barcelona. And we were able to really show that the efficacy of ivosidenib was as expected. There were no new side effects. The molecular testing was, of course, required and was mainly done by next generation sequencing. As I said, this is important to detect really all genetic alterations, and the study is still enrolling. So with this, I would like to come to an end. I'm looking forward to any discussions, but I think I hope I was able to show you that the treatment of cholangiocarcinoma is really getting more and more complex. It's a very aggressive tumor, and it requires a team effort basically to get the best possible treatment, to identify those patients that can receive local therapies such as systemic therapy. Then we need to have these then we have additional local therapies which we can apply, and what we discuss in the tumor board. And then for patients with more advanced disease, this molecular sequencing is really critical, important, and I think we are all happy that the immunotherapy is available for all patients in Canada, and this is definitely the standard of care. And if we are able to detect molecular alterations, such as the IDH1 mutations, we treat these patients with the so-called targeted therapy. Thank you very much.
Thank you so much, Dr. Vogel. So by now we go to our next speaker, Dr. Auer. Dr. Auer, is it okay that if I share my screen?
Yeah, that would be great. And then maybe I can just take control and move the slides forward.
Yes, sure. Do you see my screen?
Yes.
That's it. Great. Thank you.
Okay, sure. Would it be okay if I go to the next slide as you guide me by the next slide? I'm not sure if giving the control works now.
Oh, okay.
And
So
And
Thanks
you
very
have
much.
control.
Oh, I think I have,
Yeah.
I might have control now. I'm here.
Yeah, you have it. Okay, here we go.
Okay. So I'm going to introduce the Canadian Cholangiocarcinoma Collaborative, and thank you, Dr. Vogel, for that great overview. As Sam mentioned, I am a cancer researcher and a cancer surgeon, but my journey with cholangiocarcinoma started in May 2022 when my husband and father of our 3 children was diagnosed with stage 4. So that disease that is not resectable by surgery, cholangiocarcinoma. And that journey obviously has been really challenging for me and my family. But what I also realized is how important hope is in that journey for patients and their families and care providers, and how important it is to incorporate research and all of the incredible recent findings that Dr. Vogel had talked about in terms of molecular therapies and immunotherapies that have come about even since my husband was diagnosed under 3 years ago, really provides patients a lot of hope. And so I talk sometimes about the power of yet, and how research reminds us that even if a disease is incurable today, it very well might be curable tomorrow. And we are making progress in all of the various subtypes of cholangiocarcinoma. And this is a quote I love from Christopher Reeve that says, "Once you choose hope, anything is possible." We're going to see if this so C3 is the Canadian Cholangiocarcinoma Collaborative, and it was shortly after my husband was diagnosed. It was an effort that myself and a number of my clinical and research colleagues, as well as patients who I'd met through the journey, started to try and support patients in Canada with cholangiocarcinoma by giving them access to novel therapies, to clinical trials, and to research. So we wanted to build this national network, and we were very lucky to get, we applied for and got a grant from the Canadian Cancer Society and Canadian Institutes of Health Research for $7.5 million to initiate this. And we have a lot of research partners within the collaborative. So you can see all of our partners across Canada at various different research institutes and hospitals who have partnered with us to try and find better therapies and integrate these therapies into the cholangiocarcinoma platform. We also are really proud that we've developed a significant number of medical experts who've signed on. And these are physicians with expertise in cancer surgery, oncology, pathology, radiation oncology, radiology, and molecular. Someone on the chat saying they can't see the screen. And so we have experts from across the country who have joined in, helping to chart the course for patients and also providing support for their patients in their own region. We also have a significant network of patients and their caregivers. We have a Facebook group. We have local meetups. We have support groups and advocacy groups which meet online. And we've integrated patients into pretty much every aspect of our research, our clinical trials, design and development, our research integration, and the advocacy and support that we provide.
There's still a couple of people who are saying that they cannot see. I mean, I can see it very well. So I don't know, Sam, do you want to stop sharing and share again?
Maybe I can try, yeah. It's just I don't have the control of my mouse. It's just the control is with Dr. Auer, yeah.
Okay.
But I think that most of the people, they can see. I checked with a few people and they told me that they can see. I don't know. Maybe it's something wrong.
I don't know. Maybe just proceed. I mean, many can see.
I will stop sharing and I will share again just to see how.
So I think one of the things for me is that really this patient engagement has been, for me, such an important part of the journey. And, you know, as a researcher and a physician before this experience, I think I may not have understood just how important this piece of it is and how important it is for us as researchers and clinicians to have that patient voice at the table, to understand what their what the most important needs are and to be able to meet them. C3 consists of 3 aims. The aim that I lead is called the HOPE aim, and that's really providing support and information to patients along with helping them to, and I'll discuss it a bit, obtain molecular testing and access to clinical trials. Aim 2 is run by my colleague and good friend, Dr. Simon Turcotte in Montreal, who trained down at the NIH to do tumor-infiltrating lymphocyte immunotherapy, and has started his own program and in Montreal, and he will be leading a clinical trial, first in Canada, of tumor-infiltrating lymphocyte therapy in cholangiocarcinoma. And then my colleague and friend, Dr. Carolina Ilko, is leading our impact aim, which is really about getting new discoveries in from the lab. And again, we have researchers from across the country. Next slide. So how do patients connect with C3? We have a number of different ways. We're doing our best to try and make sure physicians are aware so that they can provide pamphlets to patients, which we've provided to them. There's also just word of mouth and social media, patients talking to patients. And then you can just visit our website, cholangio.ca, and self-refer. Next slide. Once you do self-refer, then we ask you to become a C3 member. And so you complete a short intake form with some information, sign the terms and conditions, and that gives you access to our monthly newsletter, as well as a research navigator, which I'll talk about in a bit, a patient care kit that we send, which is kindly supported by AstraZeneca, national multidisciplinary rounds, molecular testing, and we have a national registry. Next slide. So excited to say we've had 200 patients sign up since we opened in October 2024, which for a very short period of time, I think is pretty amazing for this somewhat rare cancer. Next slide. This is a picture of Christine Lafontaine. She's our research navigator. So when you connect with us, she will have a meeting with you, try and understand what your needs are and see if we can better support you. She will also assist you in joining the C3 registry, and that allows us to add data to the international cholangiocarcinoma registry. Again, because this is a rare disease, it's important for us to understand the landscape in Canada and how it relates to the rest of the world. We also have multidisciplinary rounds, which I'll talk about in clinical trial support, as well as our monthly patient newsletter and support and advocacy groups, as I mentioned. Next slide. As Dr. Vogel talked about, there are many molecular mutations, and some of these have therapies which either have been proven in cholangiocarcinoma or are currently experimental. And so patients with mutations might be eligible to participate in a clinical trial or get an off-label treatment, or some of them are already standard of care. The problem is that except for Quebec, there's no province that has a comprehensive testing program, and this was really raised as a significant issue. Next slide. So C3 has been able to help support a molecular testing program in Canada. In Quebec, it's already funded by the province, as I mentioned. In Ontario, only one gene is covered, it's FGF receptor 2, but C3 covers the additional genes that might be important for participation in a trial or off-label access. And then at the rest of Canada, we do this through a lab called OncoHelix, where we fund the FGF receptor as well as the other genes that might be relevant. And this is provided through the grant, at least for the time being, so that patients can avail themselves to this opportunity regardless of their financial status. Next slide. These ones are funded by C3. Yeah, so since our launch of this program in July 2024, we've had more than 40 tests ordered in Ontario and about 40 in the rest of Canada. We're continuing to reach to physicians and patients directly to let them know that this testing is available. And we're hoping that this testing will help support patients, for example, who might want to go on an IDH trial that Dr. Vogel just talked about. But otherwise, they wouldn't be able to know if they were eligible because they wouldn't know if they had a mutation in that gene. So I think this is really important, and we're hoping that by offering this, eventually it will become funded by the provincial governments. Next slide. And then the registry, really, we think it's important that patients are able to, if they choose, add their data to national and international registries so we can understand the landscape of this disease, but also, just as importantly, have access to their own data and have an ability to share that data with other providers if they want a second opinion or if they want to go to another center to see if they're eligible for a clinical trial. So right now we're working in partnership with Citizen to be able to ensure that patients can have a portable record of all of their clinical files, medical files. Next slide. So this is how the Citizen platform works, and currently Citizen is what houses the International Cholangiocarcinoma Patient Registry data, which Canadian patients really aren't a part of. So our future goal is to make sure Canadian patients are a part of it. Right now, they're a part of a Canadian registry, but our future direction is to have our data supported by Citizen. But essentially, a patient would register Citizen, or in this case, C3 procures the medical records on the patient's behalf, because we know that patients often don't have time or the resources to be able to do this. And then in a future direction, we're hoping that we can avail ourselves of Citizen's platform to use natural language processing or AI to be able to procure the data and then provide de-identified data about the population. Next slide. And this is just example about what one data set in the registry would look like. It has information about the treatments the patient got, their side effects, their molecular testing if available, when they were diagnosed, and all of these things. Next slide. And I should mention that from a patient's point of view, they can see the actual reports and records. So clinical notes, lab tests, radiology reports, which means it's very easy to go and get a second opinion somewhere else. This is data from the US. It's a bit old now, but it was just looking at the number of patients that had a mutation that could have a drug and whether they got that drug. We don't have any data like this for Canada, so that's what we're hoping that the registry will help with. Next slide. Multidisciplinary rounds is very common in oncology, where physicians sit in a room and they discuss a complicated case, especially one where there's no obvious next treatment plan or where we're considering a clinical trial. Because cholangiocarcinoma is quite a rare disease, there aren't necessarily a whole bunch of providers in one center who would have a lot of expertise or knowledge of clinical trials outside of, let's say, our largest centers.
So you will see protocols.
For example, Montreal and Vancouver. So multidisciplinary rounds essentially is a virtual forum where patient cases can be presented and patients can request their cases be presented. And if we review that, and if there's a reasonable question, we contact the physician and ask them if they would like to present, or if they're not able to present, if we can present the case. We procure all the data and then provide a written report back. So we've presented 25 cases, and I can say that a number of patients, their care has been changed after the presentation at rounds. Physicians are only invited to these rounds. It's not for patients, but the patient does get a report of what was discussed if their case was reviewed. Next slide. Really, C3, it's our organization. It's for you as patients, and also for care providers, physicians, and researchers. We think it's really important to help patients get access to the best care. And I think when we work together and understand the landscape, we have a better chance of advocating for what patients need. And so we are here to change in response to your needs. We're here to address what patients and physicians and researchers need in this landscape. Next slide. We also recently launched our support portal. So if you are interested in donating, it just opened today. I was proud to say I was the first donor. But our vision again is to build a hopeful future. And if you want to give back and help support this program, you're welcome to do so through cancer.ca/support C3. Next slide. Again, today is World Cholangiocarcinoma Day, and you can see all of the cities that have a lighted up green program going on. The ones with stars are where there's a meetup as well. In Ottawa, where I am, we're having a meetup at the Ottawa sign at 7:30 in the Byward Market. And the lighted up green is all over the world, but it's really just to raise awareness for this rare cancer. Next slide. We also have a Meet C3 event coming up on April 4th to 6th. It's free for patients and physicians. It's a 3-day event. The major sort of scientific day is on the Friday, April 4th at the Ontario Institute of Cancer Research. We have speakers, physician speakers, as well as panels for discussion with patients. The 5th is a patient and caregiver day where we're going to tour some labs and then also do a walk together and a meal. And then April 6th is our biannual program update where we talk about the 3 aims. More details on our website. You're welcome to register. There's a virtual option as well for the 4th. Next slide. And that's all I wanted to talk about before I introduce our amazing patient partners. But I just wanted to thank all of the people who are involved in C3, amazing clinicians who join rounds and always provide amazing opinions, like Dr. Vogel, who's always there and always looking for different options for patients. And our funders and our supporters like Servier here, who have been an amazing partner with us to help get information out and help to fund our initiatives that are so important for patients. It's my pleasure now to introduce our 2 patient partners. These are just incredible individuals that I think we've been so lucky to be able to partner with. And I'm not going to say too much about them because I'm going to let them tell their story. But first is Dana Fox, who again has been an amazing patient partner and advocate. So Dana, take it away.
Thanks, Rebecca. I was diagnosed in November 2023 after a run. They said you would live maybe 8 months. I had no hope, 0. I started chemo on December the 22nd, and we asked on multiple occasions, is there anything else we should look at, anything else we can consider? The answer was, I'm sorry, there's nothing we can do. On the 3rd time we asked, they said, maybe there's this gene mapping thing, but we're not really going to make it really available. You're going to have to do this one on your own, which we did. We got the results back, but we never really found out what we're going to do with it. It was just sort of slid off to the side. We finished our chemo on May the 31st. I did my first 5K race on June the 1st, just to say I could do this. I'm not lying down. We did the Ride to Conquer Cancer. It's 200K ride in June. I said, there, take that, cancer. We kept training and fighting back in July, August, and then I went and did the Georginas Marathon, qualified for Boston in 2025, which I will be going to. So for everyone else that said, you know what, you're not going to make it past October, I went and did a marathon instead and said, there, we're in better shape now than I was a year ago. So don't tell me it's not possible. And all of this was done with hope. So that tumor started to grow in October. They took me off of the immunotherapy that I was on, and we switched lanes. Instead of working with our local oncologist, we went to Princess Margaret. We got introduced to some very special people that said, you know what, we don't say I'm sorry, we just find another way. And that was such a great day. That's like you changed the whole course to find somebody else that says, I believe this is possible. Now anything is possible, and away you go. So anyway, that tumor thing started, and I switched over to the Tibsovo on January the 7th, and here we are. So that's my story. I'm really grateful to be here, alive, and I'm still training and working and running hard.
Amazing. Thank you so much, Dana. And our second patient partner is Ihab Altobagi, also is an incredible patient partner, and I'd love to hear his story.
Hi, everyone. Yes, sure. In July 2023, doctors discovered bile duct cancer, which had spread to my liver and lymph nodes. It was shocking news for me, my family, and friends, especially since I had just lost my father to cancer 3 months earlier. The first surgeon actually who met with my wife and me didn't offer much hope. Stage 4, rare, not many options. He advised chemotherapy, but we refused to accept that as our only path. Immediately, I started chemotherapy under the care of the incredible Dr. Sarouche at Credit Valley. At the same time, we searched for answers. We consulted more than 10 hospitals and doctors worldwide. We were just about to finalize our trip to Germany for surgery when wonderful Dr. Schwartz at Princess Margaret gave us hope. She decided to move forward with the surgery. In January 2024, I underwent cancer removal surgery and left the hospital after a month and a half cancer-free. Now, I was slowly returning to my normal life when the cancer returned with tumors in my lower back and lungs. I had radiation to ease the pain and restarted chemotherapy in August 2024. By November, another CT scan showed that the chemotherapy wasn't working. The cancer was spreading again. Just when I thought my options were running out, I was lucky to meet Dr. Vogel, who introduced me to a new trial medication. Now, 6 weeks ago, I started this new treatment, and here I am today, still standing and fighting. Actually, cancer has challenged me in every possible way, but I believe it chose the wrong person to challenge. It has only made me stronger and reinforced my belief in power of family and friends around me. My journey isn't over, but I face each day with gratitude and determination. And you can see some photos with my wife, my son, and I think you can tell that my wife likes to record everything and she likes selfies. That's it for me. Thank you very much.
That was great. Thank you.
Thank you so much. And one thing I would just say is both of your stories are so inspiring and filled with hope and courage. And that is probably the most incredible thing of having C3 patient partnerships is what it brings to me and my spirit. It reminds me of hope and reminds me of the strength in community. So thank you both for being part of that. I thought perhaps we had some pre-planned questions for discussion, but given the time, I wondered if we should open it up for questions from the audience. And then if we don't have questions, I have some questions for both Dana and Ihab already. Do we have,
I
think,
I
yeah,
have a
go
question.
ahead.
Hey there. I'm a friend of Dana's and I'm very, very interested in this and great to hear the stories and the research. I just have a quick question. I'm just wondering, I know that when Dana started and they told him, nope, sorry, you're done, buddy, off you go. Is anybody dealing, at the ground level with doctors who are telling new patients that, like, it seems like that just should not be done. It seems like people should be saying, hey, we got a couple of guys out here. We've got, Mr. Altobagi, Mr. Fox. We've got these people that are determined to find something new and we want to help you versus, I'm so sorry, you're too far along. See you later. Bye-bye.
Yeah, so I can speak from a C3 perspective. We've certainly been working with our medical experts to try and bring that message. And I think being able to offer molecular testing, I think helps our oncologists to be able to provide options that previously they may not have been able to provide. But Dr. Vogel, do you want to comment on that? Have you seen a change in the oncology group in terms of their options for treatment and stuff?
Yeah, so I think, that's a very important point. And I think when we talk about these options, we really have to acknowledge and raise awareness for that many diagnostic tests and drugs are not approved and accessible in Canada, which is really a problem. And for us as physicians, it's really important. And I mean, we are really trying hard at PMH, and we are lucky that some other larger hospitals have the opportunity and the capability to perform these tests, but they're not really reimbursed. Yeah, and I think this is a failure of the Canadian health system. And you hear my dialect that I'm not a Canadian, native Canadian. Yeah, and I'm coming from Europe, and like in the US and in most European countries, these tests are approved and also the drugs are approved, right? So therefore, I think it's of utmost importance to raise awareness for that, to make it public, to go to politicians and say it's not acceptable that there are drugs out there that are approved and recommended by all guidelines that are not really accessible in Canada. And I mean, those two patients we just talked, yeah, I mean, if we would not have the trial, we would not have been able to treat them. And I think it's for me, it's really hard because I mean, 20 years, I always treated these patients with these alterations, and being here, knowing that the drugs are available, knowing that they are effective, and then not being able to use it, I think is a problem. So I think it's good we are making progress, but we also need to make progress in Canada, and we really need to raise awareness and talk to our politicians that we need to make these drugs and tests available for all patients. And I mean, Rebecca Auer is really doing a remarkable job. I think I'm really stunned again and again whenever I heard her talking. Yeah, so I think patients can be so grateful for this initiatives. Yeah, it's really great.
Okay, thank you.
Thank you, Dr. Vogel. Susan?
Hi, Dr. Auer. I'm wondering, I watched a seminar on the American CCF on histotripsy, and I wonder if you could comment on your thoughts on that process.
Yeah, so I'm not an expert on histotripsy for sure. It's a local treatment, so it's really good for patients who maybe have like some bulk of disease in the liver. We certainly have had some Canadian patient partners who have gone down to the US and been treated with histotripsy. And currently, my understanding is there's nowhere in Canada right now where it's available. We do, however, in Canada have other local treatments, and I think Dr. Tagar is on the line. He does like a radiation type targeted treatment. We have other treatments like ablations and stuff. So it's not the only local treatment for disease in the liver. But I think it's starting to gain some traction, and it'll just be interesting to see where it fits.
But I think it's important to highlight also that, I mean, this tumor is really highly aggressive and really has a high potential to spread to different parts of the body, right? And with these local treatments, and histotripsy is extremely expensive. I mean, it's not covered by health insurance companies. And I think we, as Rebecca said, we do have a couple of options available that can be used everywhere. And I think here it's really important that these patients are discussed in multidisciplinary tumor boards to always evaluate what is the best treatment. And histotripsy could be one treatment, but there are many others also available.
Okay, and so how do I access those? I'm in Edmonton at the Cross Hospital, and we pretty much have the standard of care, and that's it. Anytime I ask about anything different, you know, I was told at one point by my oncologist, I have no idea what trials are out there, and it's just a bit frustrating to hear that there are so many options, but how do we access them?
Yeah, but I mean, there are options, but not for many patients. There are many options, but not for many patients. What I said in the beginning, unfortunately, for many patients, we cannot use these local treatments. Yeah, but I understand your point, and I think, I mean, second opinion is something that, and I mean, Ihab said before, I mean, he went to, what did you say, 10 different physicians, right? So I think you can try to get a second opinion. And I mean, in the large university hospitals, you should get a very valid response. And if there's something feasible, I think it will be done.
Thank you.
And Susan, have you connected with C3? Because it might be possible that we would be able to help you with some clinical trials or even, you know, have your case presented if there's a specific question, whether local therapy is reasonable. Sometimes it's not that they can't do local therapy. Sometimes it really is that it doesn't make sense. As
Right.
Dr. Vogel says, if there's disease elsewhere, then targeting the big one in the liver doesn't change anything. So I'd be happy to have our team connect with you, or maybe you could connect with us if you haven't already.
Yeah, that's it. I tried. I need some help, but I will connect and get that updated.
Yeah, let's try and see if there's something we can help to offer for you.
Okay, thanks so much.
I think we just have a couple of minutes left, and maybe I'll just pose one last question then to Dana first and then Ihab, just about how to navigate that situation if, let's say, your oncologist doesn't, as you experienced, Dana, doesn't seem at all interested in maybe ordering or providing molecular testing, or doesn't know about trials and isn't really offering you a lot of hope. How do you as a patient navigate that, and what do you think advice you might provide to patients about that?
What we did back in December, I would not do again. I just asked our oncologist, and when they said no, there's no other option or no testing, we didn't know, and I just took the answer and said, well, I guess that's the answer, and we stopped. Once we found out about gene mapping, I thought, okay, the advice we got from the Cholangiocarcinoma Foundation down in the States was probably correct. If they don't know how to spell cholangiocarcinoma and they don't know about molecular testing, you're probably working with the wrong oncologist. You need to find somebody that knows about this and says, look, if you want access to these trials, you need to get the testing done. The gene mapping needs to be done. And the drug companies aren't coming to Canada if you've only got 5 people that's got testing. They can't do a trial with 5 people. They need a trial with a bigger sample size. So unless we can assist with getting more people up here in Canada to get the gene mapping done, it's very difficult for the drug companies to say, well, let's invest in the trials up in Canada. The numbers will be too small, and we'll be, resort to going down to the Cleveland Clinic or someplace saying, can you help me? When I know that we have very knowledgeable, very skilled people right here in Toronto, as an example, at PMH. So it's tough. I had to ask 3 times to find out about gene mapping, and it was on a scrap of paper. It was like a secret code. Don't tell anybody I shared this with you. It's Foundation 1. And here, if you click on this, you will find out about gene mapping, but don't tell anybody you got it for me. Because you know what? This is going to cost you $5,000 and I don't have the money. So you're on the hook. I thought, okay, you know what? I don't care. In 8 months, I won't be here. So let's go spend the money and find out what's the solution. And oh boy, get the report back. It says, guess what? You're not the only one. And here are a bunch of solutions that are available. And here's where they are. I thought, wow, this is crazy. It's down in the States. What can we do here in Canada? So, good news for me. It's like, that's when we bumped into Adam and we had a discussion with yourself. And it's like, this is not over. Don't give up. There is hope. There is gene mapping that gives us clues as to how to take this personalized medicine and apply it to people like myself that says, I'm just looking for a way to just go after this thing. Do you have anything that might work? The answer is yes.
Thanks, Dana. I'll just let Ihab have the last word if you have comment there.
For me, I was very lucky that my oncologist, Dr. Arif, referred me to Dr. Vogel, so I didn't have to go through all the struggle. So it was good for me.
Yeah, great. Sam, I'll pass it back to you. It's just past 7 now.
Yeah, so it's very, very on time. Thank you so much. Thank you of our amazing speakers and all attendees. It was great that in this World Cholangiocarcinoma Day, we were together, we supported each other, and it's all about the hope So now it's also at 8 p.m. It's the hockey game. So let's hope for the win of the Canadian team. And I guess we can wrap this session.
Can I say something?
Yeah, sure.
I was trying to get my opportunity to talk a few times, but I wasn't able to.
Sorry, I didn't
I
see
thought
your hand raised. Sorry.
I thought at the beginning, if we had anything to say, we just needed to raise our hand.
Okay.
So I want to thank you all for the information. It was very informative. I'm a patient. I was just diagnosed in July of 24 with bile duct cancer. And when I was diagnosed, I was also, they had to put stents in my Wirsong and the coloduct area, if that's the right word. I'm not a doctor, so you'll have to bear with me if my words are not proper. So I was diagnosed in July. I started my treatment in August. I had 8 treatments, 2 weeks on, 1 week off. My last treatment was in February the 6th. I had a CT scan on the 11th of this month. I was hoping at that point that I was going to continue with a immunotherapy because everything seems to be going in that direction, but unfortunately it did not. So now I'm scheduled to start full FOX treatment. Can everybody hear me? Oh yeah, okay.
Yes, yes.
All right, I just got some voice in the background. So now I'm scheduled to start full FOX on March the 4th. I also had the opportunity to talk with Christine LaFontaine a couple of days ago, the research navigator from your group. And also she introduced me to the possibility of maybe the HIP or the HAIP or pump, which is available, but not necessarily in Canada. But that same pump is available in Toronto for the colorectal cancer, I believe. Maybe Dr. Vogel can talk about that in a minute. I guess where I'm at, you can see where I'm at. I'm at a juncture where Dana was a couple of years ago, where I'm basically at a point where Volfox will not provide me a long survival time. So I'm just throwing it out there. Maybe somebody can throw back some. Oh, by the way, I'm from New Brunswick. My doctor is Dr. Eve Saint-Hilaire. She's my oncologist.
I mean,
the floor is open.
What I can only say that, I mean, it's of course important, and this is what we have discussed before. I mean, this genetic testing is important, or gene mapping, however you want to call it. Yeah, so you should really try to get this done. FMI has been mentioned before. I mean, this is a way how to do it and pay for it, unfortunately. But I think C3 really offers now a good opportunity to get this testing done. And for local therapies, these intra-arterial infusion high treatment, I think it's an interesting option, but this is something that really needs to be discussed in a tumor board. And I mean, I think it's really important for these cases with liver-limited disease to get a discussion in a tumor board, and it could be either in some of the bigger hospitals. I mean, in Toronto, of course, or Rebecca Auer also mentioned that she has this tumor board where cases are reviewed, and I mean, but it depends a little bit that you reach out to your treating physician to refer to these tumor boards. Yeah, but I think it's really worthwhile to do it because, I mean, if you have more people involved, you can be sure that you get the best option and that everything is really explored that may help you.
Thank you. I've already, my treating doctor has already requested molecular testing from your group. I hope that it has been done in the last couple of days after my discussion with Christine Lafontaine. So that's where I'm at this point. So Dana, it would be Dana. It would be nice if we could get in touch at some point in time, one-on-one. I would really like to hear your story.
Go to smartgov.co. You can get my book. It describes this in detail, this whole journey, Surviving Cancer Marathon. And you can click on it. And when you do, it will send me your email address and I will write you back a note and we will set up a time to talk whenever you're ready.
Okay. Thank you,
Can
sir.
I jump in just for a few seconds? Because I know you're based in New Brunswick. I'm based in Quebec City, which is not too far from your home. Have you ever had a second opinion?
No.
No? So maybe you should travel to Quebec because it's so close. I was lucky enough to have surgery at Le CHU de Québec. It's Dr. Carl Degg that did, because I had first, when I got my diagnosis, I was not operable and I was not a candidate for a liver transplant. And finally, the doc, like I had a second opinion and he chose to take a risk and do the surgery. And I'm NED, it's been 3 years now. So maybe you should travel to Quebec and we can reach out. Ask Christine, she has my contact information. I would be very pleased to help you out if you want to. My name is Julie.
Okay, Julie, merci. Question to you, it's not a question, but in my case, the cancer is started in the bile duct and then went directly to the liver, and that's where it's at. There's no cancer anywhere else but the liver. But all 8 segments have been affected. So that's why they were not able to do a Whipple procedure, and the doctor said I was no candidate for a liver transplant as well. So that's
You could be very surprised. Having a second opinion sometimes can change the whole idea or the way they want to approach your disease. So, and there's other people, I mean, Carl Degg is one of them, but there's, you know, good doctors in the CHUM. There's other option as well at McGill. I mean, you just need to maybe travel a little if you're willing to do so. And
it's only 10 hours from here to Montreal.
I know, it's no big deal. So just reach out to Kristen. I can provide you a list of names of hospital and doctors and you can go from there. It's a start, at least.
All right, Julie, merci.
I
was just going to make one comment. Sorry, I'm off camera. I'm trying to get to the Ottawa meetup, but about the hepatic arterial infusion, it currently is not available in Canada. There is a clinical trial at the NIH in the US, which Canadians can participate in without paying for hepatic arterial infusion. It's a little bit restrictive in, you know, what patients are allowed to join, but it is an option, at least for now. With what's going on in the US with the NIH funding, it's hard to know how long that will be an option, but currently it still is an option. And of course, you know, when you connect with Christine, we can kind of look at your file and see if that would be something to consider as well. But again, I agree with Dr. Vogel and everyone that, you know, sometimes it's not the right approach. Sometimes it's a much better approach in the molecular space. And
I just wanted to add something. I'm one of the oncologists here in Toronto, and I know Dr. Vogel and Dr. Auer. I'm a radiation doctor, and I've been sort of part of C3 on and off. For hearing all these stories, one of the things that jumps out is often, you know, local therapies, especially in Lisette, your case, may be something that you may want to consider, either surgery or other local therapy if it is very limited disease. And getting a second opinion is the absolute right way to go, not only getting your molecular testing done or gene mapping, but perhaps getting a second opinion. And certainly at an academic institution where the cases are all discussed in a meeting, we can be sometimes more aggressive in treating and provide that hope. And that's certainly the case here in Toronto for us. we have more support from our surgeons, medical oncologists, genetics, as well as radiation oncologists. So
Thank you so much. I hope, Dr. Gallant, you get your answer to your question. And that's good that now you are in contact with Donna and Julie also. They are both for the patient advocacy. They are working with patient advocacy. There is also one more question. If Dr. Vogel and Dr. Auer, if it's okay, I will ask this question. And after that, we can close the event. It's the question of Andy and Patty. They both asked that for those of us with no identifiable markers, are there any clinical trials available?
Without markers, you said?
Yes.
Yeah,
with no markers.
So at the moment, there are not too many clinical trials ongoing. But I mean, what we have discussed before, I think it's really important to have a team discussion, multidisciplinary team discussion, second opinion. I mean, it could be in Quebec, in Toronto, wherever you are. But I think getting a second opinion is really critically important. And sometimes there's more possible than you initially think. And trials are coming and going. So it's always, you need to update basically every other week because we do see trials coming on a regular basis.
Okay, thank you so much. Great. And I think there is no more question. And by this, maybe we can wrap up the session. And again, thank you so much, all of you, for your attendance and all our great speakers again. Thank you. Have a great evening.
Thank you.
Bye-bye.
Bye-bye.
Thank you.